Welcome to Unit 4 of Transitioning to Value-Based Care. Both lectures in this unit are all about operational needs for value-based care to be successful. In Unit 2, we looked at leadership needs for value-based care success, which certainly needs to come before any other need can be addressed. In Unit 3, we looked at financial, administrative, and clinical data convergence, which may be the number one need that leaders should support for value-based care success. Operational elements associated with value-based care success, however, are often overlooked or given short shrift, something I do not want to happen in this MOOC. So in Unit 4, we will focus on both provider and health plan operational needs. We will also look at what we're calling care delivery needs, which really are the needs relative to patients specifically. We will assure we are distinguishing between quality of care outcomes versus process improvement, and we will emphasize the need to not just measure using consistent metrics, but report and improve. We will then look more closely at the state of affairs regarding quality and performance measurement and the best practices, workflows, and continuous learning that will lead to real improvements with value-based care. Within the context of improvement, I also want to revisit and emphasize the importance of what one article describes as ensuring the values in value-based payments. That is, ensuring that new skill sets of leaders include the ability to recognize and or not overlook potential new ethical challenges in value-based care, and to find ways to ensure we preserve our values as we move forward. Just to note, there are not really two separate topics in this unit. We will take a natural break to divide up this single topic into two lecture segments. Now let's look at quality of care outcomes versus process performance and measure versus reporting improving. The National Committee for Vital and Health Statistics, or NCVHS, is a statutory advisory committee to the Secretary of the U.S. Department of Health and Human Services on vital statistics, birth and death certificate data content and use, and HIPAA transactions, code sets, identifiers, privacy, security, and patient medical record information and electronic exchange of such information. A physician who worked at Kaiser and served a few years ago as chair of the NCVHS is frequently quoted as observing that we must stop talking about quality measurement. Quality measurement does no good without reporting and improvement. He was such a firm believer in the need to focus on effectively using measurement data that he always used the full set of terms quality measurement, reporting, and improvement when discussing this topic. I believe he was right to do so. We're going to address this head-on in a few moments, but we have a massive amount of quality measures, which we noted should be referred to as metrics, but frequently are not, and not nearly enough reporting and improvement. In fact, there are still many physicians who practice without knowing their individual quality measurement results, and even under MACRA, quality reporting may be at the group level. Nurses and other clinicians are also often supplied only aggregated outcomes results if measurement of the quality of their specific outcomes are even measured, which we must observe is challenging to do given that it is the overall treatment outcomes primarily relying on physician direction that are most often measured. Interestingly, the reverse is more true when measurement focuses on process or performance. Measurement of physician use of best practices is less frequently measured and hence often not evaluated for improvement opportunities than nurse or other clinician processes, such as timeliness of medication administration or errors in documentation. These are considered in their reviews and steps are taken to make improvements. For value-based care to succeed, we clearly need to measure outcomes. And while process measures are currently being maligned, they can be helpful in understanding less than desirable outcomes results. However, I do believe process measurement should be local. There certainly are opportunities to improve on processes that lead to better outcomes, including even the potential for improving on an already successful outcome in ways that may not be fully realized from outcomes measures alone, such as time and cost overruns. The scenarios on this slide comparing outcomes versus process measures and then measure versus reporting and improvement certainly point to this. In the case of the outcomes versus process performance, some examples are for outcomes are a patient's lab results within normal limits after administering antibiotics. Is range of motion within designated norms 3 months after joint replacement? On the other hand, process performance describes how a treatment regimen was performed. For example, was evidence from research included in making a decision that surgery should be done instead of administering a drug? Was an equally effective generic rather than brand name drug prescribed to reduce cost? Now let's look at either of those situations in a measure versus reporting and improvement perspective. Measuring is determining what results or how many times the treatment regimen was followed that did or did not reflect best practice. For example, Dr. A's joint replacement led to 99% of patients receiving desired range of motion within 3 months. Dr. B's results were 97.5% on the same measure. Reporting refers to the fact that those who can impact results or performance, Dr. A and Dr. B, are told what their results are. Improvement requires specific actions to be taken to cause measurements to reflect better outcomes or performance. Dr. A studied the 1% with less than desirable results and decided to personally call those to inquire about their physical therapy and diet. Dr. B thought his results were just fine and did not make any changes. So it is clearly important that we consider operational improvements needed for value-based care to succeed, that we keep these definitions and key points about quality measurement, reporting, and improvement in mind. Operational needs for value-based care vary somewhat by stakeholder, such as provider organizations, physicians separately, health plans, and others, including patients, although primarily in how needs are expressed and not as much in what needs are identified. The list on this slide identifies the most commonly cited needs by all stakeholders, from most important or most frequently cited to lesser importance from a relative perspective, or at least less frequently cited by all stakeholders. In other words, every stakeholder cited information infrastructure as issues, while most cited new competencies in customer service, although generally further down their list in importance. Let's go through these. Information infrastructure includes the need to address interoperability, although not well defined, as we'll discuss in a separate lecture on interoperability. Data sharing between providers and health plans, and even with patients. Access to data in real time while waiting for data cited frequently as a source of contention between providers and health plans. Good data, largely referring to accuracy, completeness, etc. Different types of data, though without specifying precisely what data. Integration of financial, administrative, and clinical data, as we've previously discussed. Clinical decision support, primarily through electronic health records that would support use of care protocols, and advanced analytics and business intelligence. So number one issue truly is information infrastructure, the technology, the practices, processes, etc. Process improvement was one of the next most frequently cited, although not well defined either. Sometimes interpreted as care standardization improvements and other times focused more on care coordination. Revenue cycle, return on investment, and total cost of care was number 3 in our list, and we've discussed these in Unit 3. Payment reform and flexible models for physician compensation, with providers keen on returning to the practice of medicine, quote unquote, and not numbers of patients seen, even as providers are more reluctant than health plans to adopt value-based care. Cost reduction is acknowledged by all stakeholders as important. Growth, expansion, and revenue generation was cited by all stakeholders as an operational need as well. Well understood and aligned metrics and measurement was cited more frequently by providers and physicians, as health plans can dictate a standard to be used by contract, where providers then must manage many different sets of standards for each of the many contracts they have, including Medicare. New competencies were frequently cited as a need for value-based care success, especially in care management, care coordination, risk stratification, contract negotiation, and customer service. Physicians also recognize their need for a better understanding of what they are calling health sciences, health systems science. In other words, what is the system of health care delivery in the United States? Although not often characterized as a new competency, better leadership was frequently identified as a need, and demand for behavioral health specialists frequently cited as a special need, though not a new competency. Clinical technology was something of a surprise to me and only cited by providers and physicians. But clinical technology, of course, will help improve our care. Now let's take a look at this list from the perspective of providers versus health plans. As one of the critical needs for value-based care success in all aspects, leadership, financial, technical, and operational, as this is aligning providers and health plans, I think it is insightful to take a look at what and how they separately have described needs for value-based care. In this slide, providers are described collectively, that is, organizations and physicians. We'll separate out physician needs on another slide. Health plans in this comparison refer to private commercial plans, not government-funded Medicare, Medicaid, and other such programs. The lists of needs have been compiled from a scan of the recent literature. See the references at the end of the next lecture in this unit, and interviews conducted as part of a personal client engagement. Looking over the two lists of needs, comparing providers' needs with health plan needs, I think it is actually remarkable how much commonality there is. Both providers and health plans need much better information infrastructure, and for very similar functions, including real-time data exchange, data sharing, expressed a bit differently but meaning communications with each other. Different types of data, although as previously noted, not well defined as to what different types of data are needed. Obviously something we're going to have to think about in the future. And more automation in general. Even on the health plan side, where you might think that they have everything automated, they don't. They have a lot of paper. Even partnering on the provider side and market alignment competition on the plan side are essentially the same focus, working together and often with your competitors. Value-based payment models is a higher priority for health plans than what providers call payment reform. Medicare issues are top of mind right now for providers, so likely to be the focus over other forms of payment reform. And of course, Medicare includes value-based care. But plans are also focusing on Medicare and Medicaid, albeit in different ways for different purposes. Suffice it to say, Medicare has always been the 500-pound gorilla, even as it professes to have reduced its weight. But both providers and health plans are concerned about cost reduction and revenue production via better revenue cycle management or expansion growth of business, or both. Both entities also have identified a focus on patients' customers, although in the case of providers, and particularly hospitals in this case, physicians are considered a customer for improved relationships. And in the case of health plans, customers are a broad mix of employers, providers, including physicians, and individual members, that is, the provider's patients. In expressing this as patient experience and customer service, I think the point is to focus more on consumerism, whoever the consumer is. What is surprising to me in this list, however, is that clinical quality improvement is generally not called out by health plans. For providers, clinical quality improvement is always top of mind. Health plans may be respecting the fact that clinical quality is largely the domain of providers, although health plans have also had influence in this area. They may be more focused, though, on waste reduction over pure quality improvement. In some respects, the focus by providers can also refer to overcoming the quality measurement burden that health plans do not experience because they have only one set of measures they impose on all the different contracts that they engage. Interesting also, however, is the expression by hospital and physician leaders in focusing on quality improvement and their financial leadership referring to this as care standardization, a much hated concept by physicians in particular.